here with GU Oncology Now today with Dr. Ghoreifi. Dr. Ghoreifi has multiple posters he's presented over this year's AUA. We're going to talk about one in particular. He's a fellow at Duke, and he did some pretty good work on advanced urothelial carcinoma. So tell us about what you did.
Yeah, thank you so much for having me today. So this is specific abstract is about consolidative surgery following EV Pembro immunotherapy. We know that EV Pembro is actually approved for the management of advanced urothelial carcinoma. We have the recent trials that show the efficacy and safety of this regimen for patients with advanced urothelial carcinoma, but we don't have good data on the surgical management after receiving this type of immunotherapy.
Right.
So in this abstract, actually our aim was to report the surgical outcomes, i.e. intraoperative and 90-day outcomes following consolidative surgery in patients who receive upfront EV Pembro.
Okay, who were included in your study?
So we included 17 patients who had this type of surgery in patients who got upfront EV Pembro immuno in our center. This is a single center retrospective study. The patients cohort includes 11 patients with bladder cancer and 6 patients with upper tract urothelial carcinoma.
These patients had advanced urothelial carcinoma. They're treated how long after in between the immunotherapy and regimen to
Yeah,
surgery?
that's good question. So these patients receive a median 4 cycles of immunotherapy, and the time interval between completion of the immunotherapy and the surgery, the median time was 5 weeks.
Okay. Was scans done in between to evaluate?
Usually we do the scan after completion of the immunotherapy to assess the effect of immunotherapy, because most of these patients were unresectable at the beginning, so we followed those patients with the imaging to make sure that they are resectable and we can proceed with the surgery.
In these cases, was the surgery more difficult or not as difficult, given the extent of the disease?
Yeah, so this is actually the aim of the whole concept of this actually abstract. We don't have objective tool to assess the difficulty or the complexity of the surgery, but we use some other variables as a surrogate to assess the difficulty. So we assessed the intraop complication, so there was no intraop complication at the time of the surgery, and all the surgical margins were negative. So, but we didn't have a control group to compare this group of patients with treatment-naive cases. What's
the thought process behind this, treatment, control, treatment? Like, what are you hoping for?
So actually, because we don't have, we know that based on other studies in either urothelial and kidney cancer, we know that immunotherapy may cause some tissue effect, and they can complicate the surgical intervention. So the whole concept behind this is to show the feasibility. For example, if the patient is unresectable and receive the immunotherapy and the imaging shows some good response, so the surgeon can proceed with the surgery with more confidence without the fear of having more difficulty or more intraop complications compared to the treatment-naive cases.
I see. And so this is obviously the first step. You're going to follow these patients for a while. What's the hope to see? What are you looking for?
Yeah, so the other part of the abstract actually that we didn't discuss was the pathologic response in these patients. So we showed that in this subgroup of well-selected patients, the complete pathology response, i.e. Patients who achieved T0 and 0 at the final pathology, the pathologic CR was 56%, which is actually it's a very good response.
Yeah.
And 75% of these patients actually experienced downstaging. And we had 3 patients who were node positive at the beginning, that they were like node negative after consolidative surgery. So this is very important. And we didn't report the oncological outcomes, like long-term oncological outcomes, because these are very recent cases. Sure. But in future, our aim is to follow these patients, comparing the outcomes of patients who received complete response, partial response, and those who didn't respond to immunotherapy. What's the outcomes of these patients if we need to continue immunotherapy like as an adjuvant in an adjuvant setting, or we can, like for those who are received who achieved a complete response, we can just follow them without any other type of systemic therapy.
That's very cool. So these patients, they're in this trial, they're basically, you're going to manage them and see how it happens, if they have recurrence or not.
Yeah, exactly. This is like the whole concept, and we definitely going to expand our database, add more patients, and follow them to see what's the long-term outcomes of these patients.
That's very cool. So this is a consolidative neoadjuvant therapy regimen?
It's some of these patients, I call them like neoadjuvant, but some of them actually, for those who were like completely unresectable, they received the immunotherapy with a like treatment dose. So these are actually, I classify them in a like different way, these two groups. Yeah.
I see it. And in terms of the complications in the 90-day, so what do you find?
Yeah, so actually the 90-day complication in this group was 69%, and 19% of these complications were high grade, i.e. grade 3, that required some sort of like intervention. But we didn't have any mortality, no, like intra-op or post-op within 90 days, there was no mortality.
Okay. And in terms of you did cystectomies with conduits for most of the patients?
Most of the patients, yeah, they had cystectomy. Among 11 patients with bladder cancer, all of them actually had cystectomy. We had one case that was aborted, and that patient was like a very special case that he had a history of testis cancer 20 years ago, and he received radiation therapy for that. So we think that that frozen pelvis was the result of that radiation, not because of the immunotherapy itself.
Understood. And was any of these more of a more extensive resection involving more of the pelvis or anything like that?
No, actually, in terms of like the surgical intervention, it was like a routine cystectomy, similar to like other patients who received conventional neoadjuvant chemo or like treatment-naive cases.
Very cool. And what's the follow-up regimen now for these patients?
So in terms of like immunotherapy, you mean? In
terms of imaging.
No. Yeah, so we continue following these patients based on the guidelines. We do the first CT scan within 2-3 months after the cystectomy or nephrectomy, and we continue the management based on the final specimen, i.e., for example, for those who still had residual disease, so there might need like adjuvant treatment. But for those who achieved a complete response, we continue imaging, and if we see any like recurrence or like any disease or progression, so we might consider those patients for like another line of immunotherapy.